Hi, everyone. My name is Anita Chandra, and I'm Vice President and Director at the RAND Corporation. I run a division called Social and Economic Wellbeing, which covers many of the topics that are thematic in the conference, health equity being chief among them, but other aspects of environmental policy, science and technology policy, criminal justice, and economic equity. And it's really a pleasure to be with each and every one of you today. I'm sorry that I can't be there live for the virtual conference, but I'm so appreciative to the conference planners to allow me to pre-record a presentation today. My presentation is entitled A New Era for Communities to Thrive. What will it take to advance well-being post-COVID? The presentation is organized in three areas. First, I thought I would step back to step forward to talk a little bit about factors that are driving us to a well-being conversation today, a more holistic way of thinking about not just traditional health, but well-being overall, and where equity or health equity in particular situates in that conversation. I want to share a little bit about what I see as the opportunities for reimagining what it takes for communities to thrive, which stems from work that I and others have done at RAND and with collaborators across the country, and to identify some places and spaces where I believe that questions still remain for our field going forward. Now, it's good to kind of level set the frame of this presentation because we often talk about how are we going to take the lessons from COVID and do things differently. So we often talk about the before times and the after times, meaning after COVID, after the events of 2020, after some of the conversations were sparked around equity and racial justice. Now, to be sure, we're still dealing with COVID, lest we get complacent, but we are entering a different phase of the pandemic discussion. So before we get into the after times, as we go forward as a set of communities and as a country, it's useful to look at what did we know about health? And what do we do about health in the before times? So many of you are familiar with this chart. It's a classic one, and unfortunately, the numbers are not changing in a favorable direction for the US. But we spend nearly 20% of our GDP, or our gross domestic product, on healthcare alone. It's important to note that this is not all of the spending that we have on health. It's the spending specifically on healthcare or medical care. If we were to calibrate or calculate the larger health spending, it could be more than this. And so this is sobering in and of itself, particularly as we relate it to other developed nations. And why it's particularly challenging is while we spend a lot on our healthcare, we don't always confer the benefits in terms of our health and related outcomes. For instance, we're not getting the returns in life expectancy compared to some of our developed nation counterparts. And if you look at things like life satisfaction, which is often a marker of evaluative well-being, we're not seeing anything distinct. Similar patterns persist, with the US much lower than other countries. And why does that matter? Well, we know it matters in terms of health and mental health specifically, but we also know that things like life satisfaction, of course, life expectancy, matters for the economic and social progress of a nation. The other thing that we were doing, which was we were spending a lot focused on just the medical care piece of health. Now, of course, that's critical, and we want to have important healthcare services available to all. But we were spending close to 90% on medical services and far less on other variables that might be addressing behavioral change in health or other aspects of health and the environment. And why that differential is important is to note is that it is misaligned to what actually makes us healthy. About half of our health is coming from behavioral choices at the individual and household level. About a fifth is coming from the environments in which we live. Certainly a fifth is coming from our genetic map. And only about 10, sometimes 15%, depending on the study, is really being driven by medical services. And even when you look at the issue of behavior, arguably, behavior is shaped by the interactions with systems, structures, history, and the environment. So it's not simply that individuals are making personal choices separate from the environments in which they live, but they're interacting, whether it's access to healthy food environments, access to clean environments, and certainly the structural legacies of things like redlining or environmental inequities built into some of our systems. Now, we were on an interesting path at the time of a couple of years ago where arguably 4 trends in health were starting to align. One was that we were moving to a framework of health in all policies, or as I like to say, health in all decisions. And the reason why that's important is that we were starting to have really meaningful cross-sector dialogue between traditional health, healthcare and public health, with other sectors, transportation, public works, economic development, and in some communities taking really big steps to try and tie together budgetary or other investment decisions to a framework of health and health impact. We also are starting to embrace a broader well-being focus, which I'll talk about in a little bit later in this presentation. And that was being driven by a reemergence of conversations about what drives health, the multiple dimensions of health, that it wasn't just physical health, but it was also mental, spiritual, and social health. And people were going back to the WHO, the World Health Organization definition of health, that it wasn't merely the absence of disease, but the presence of these multiple dimensions of health. As we started to think about environment, the protection of communities and the planet, we started to broaden a little bit more of how health conversations were situating in a larger well-being conversation. We also were starting to have real conversations about disparities and saying that just looking at gaps between groups, Black or white, low income, high income, was not enough. We had to look upstream to the drivers of equity or health inequity, which meant looking at the definition of health equity, which is the fair and just access to the opportunity to be healthy, and the need to dismantle or remove some of the structural barriers that makes it difficult. And because of all of these other things that were happening, we were talking about the integration of health investments, whether it was balancing where we're spending our health dollars across healthcare, public health, and social services, or also how we were connecting it to that health in all policies or health in all decisions framework. And through all of this, we were perhaps not explicitly, but at least implicitly starting to ask the question, not just about how do we mitigate disease, but ask what actually produces health, what actually helps communities thrive and flourish. Well, of course, there was a lot of momentum and a lot of excitement about some of these new conversations, and then COVID hit in the spring of 2020. And not only did it upend our health system, but it upended other related systems and exposed that even with our exuberance and the progress that I outlined on the prior slides and a growing recognition of the social determinants of health, that we still had missed a lot. There were communication challenges of how we talked about the value of health and data challenges, still limited coordination across sectors. So as much as particularly in health and public health specifically, we had invested and prioritized collaboration across sectors, we still saw an unfortunate pitting of economic decisions against health decisions when we know they're inextricably linked. We had challenges in many cases of getting the kind of data in real-time way to proactively address inequities, whether disaggregated data by subgroup or capturing data that allowed us to place testing in the right locations or think about vaccination when those were available. And then certainly there were systemic fragilities that certainly belied a deeper lack of connection and consideration of rooted inequities, deep legacy and structural issues that we had only scratched the surface on were rearing their head within and across systems during the pandemic, which is ongoing, but certainly during the acute phases of the pandemic in its first year. So as we go from the before times to the after times, the question for us is, can we be better in 3 ways? Can we act on what we knew before COVID, all of those graphs and charts I shared, with greater urgency and focus? Can we get our investments aligned to what influences health? Can we think differently about our data systems? Also, can we be more holistic, not only about our recognition of all of the drivers of health, but what the purpose of health is in the first place? And as I'll share a little bit later, what are the narratives that frame health? And then finally, really thinking about not only health equity in the context of just the last couple of years where there's been heightened awareness, but how do we move from the rhetoric of health equity to actually structural and transformational change? These are questions that we have to grapple with. The way that I think about it and the way that we've organized some of the work that I'll share is that there are three areas for which we need to have action: concurrent and interdependent action. One is reimagining the health narrative in the first place, and that includes the narrative around equity and well-being. A second is to revisit what we're measuring in the first place and using data to drive community change. And then, given that issue of rhetoric to action, how are we instantiating and integrating many of the transformational things that we seek to do because we learned so much during COVID into our policies and systems? So I'm going to step you through essentially three streams of work and highlights from some of those research and other projects to help us illustrate how we might think about addressing those three actions of narrative, measures, and policies and systems, and to attempt to address those three after times questions: how we take the moment of COVID to do something proactive and positive, how do we think about health equity in a transformational way, and how do we reframe the health conversation in the first place? So in stream one, I want to talk a little bit about some work that we've been doing for the last several years to look at both community narratives around health, but also individual perspectives and mindset about health, well-being, and health equity. In short, where is the American public on health and health equity? And where are communities overall on the conversation about health, well-being, and health equity? So let me start first at the community level, and then I'll transition more to where an individual public sentiment is. So we've been privileged to work over the last several years with the Robert Wood Johnson Foundation on their efforts to advance a culture of health in America and to advance movement on health equity. The goal of the larger effort is to make change in not only how Americans think about health, but to move actors and influencers towards new behaviors in health and to ultimately address structural inequities that are undermining our progress on health and broader well-being outcomes. One part of that effort that we've been involved with the foundation is something that we call the Sentinel Community Surveillance Project. The reason that we call it Sentinel Communities is that we've taken a very naturalistic approach to monitoring how a set of communities are advancing on a culture of health, not in an intervention way or a place-based ways, but in many ways how we think about Sentinel data systems that helps us surface the emergence of new phenomenon. We took it and we put it in the context of culture of health. So we've been monitoring activities related to how a culture of health has been developing in 29 diverse communities, including in Nebraska, and I'm happy to point anybody to that work. And we've been excited to essentially use key informant interviews, environmental scan, document review, and various ways of observing at a distance how communities have worked within their own historical context and structural legacies to improve health, well-being, develop systems that promote health, and address health equity. And we've been doing this for 5 years, and some of that work will continue going forward, but it has been illuminating to understand what are the facilitators and barriers to moving along a community, both in terms of embracing a shared value of health, thinking about cross-sector collaboration, supporting healthcare systems and public health, and really advancing healthy environments. We have a report out now, which is noted here in the footnote, where we looked at how narrative was emerging in these communities, both before and during COVID, to understand what were the frames or the ways that communities were talking about and conceptualizing health, what were the resultant messages and stories that they were using to capture that narrative. And what did that look like? And what did it mean in terms of the context of where a community was and where it was trying to go in terms of not only making progress on health and well-being outcomes, but making progress on health equity specifically. So this schematic is in the report noted in the footnote, and it steps readers through all of the factors that we know influence, particularly the frames part of a narrative. This includes mindsets, how people view the influences on health and what drives health, the values that people bring to health, but also broader values like libertarian values, cultural values, and the like. Experiences that that community might have had with particular events, disasters, emergencies, other seminal elements in that community. The culture of that community, as many of us who work in communities know, communities have subcultures, and then they also often have an overriding culture. What binds the people of that community together? And then finally, the history, both the history of that community, but also the history of individuals in that community, whether there are legacy issues of racial or other structural inequities, as well as other aspects that drive the historical context of a community. We know that this all matters with how communities approach health, how they frame health, and yet too often this is an underlooked, understudied area of our health work together. Now, telescoping out from the frames, we also know that it's not just about describing the frames in a community and saying, hey, this is how people are conceptualizing health in a community. Isn't that interesting? But it matters because it leads the influencers in a community in terms of how they message, how they articulate, how they prioritize. And it also leads to demonstrable actions on behalf of health, cultural shifts in what we value in health, programmatic change, and of course, policy change. So as we were studying the subset of sentinel communities, we identified essentially 5 frames. Now, I want to note that many communities have multiple frames working at once. They're often working at opposition at times, and sometimes in complementary ways. There are sub-frames because there are subgroups in communities. But many communities at least can be characterized by a dominant frame and ultimately a dominant health narrative. And why that matters is that the dominant health narrative tends to be the main driver of systemic policy and programmatic change. So if you want to make progress on health well-being and health equity, which of course is the theme of this conference, then you have to think about where communities overall are starting in terms of their frames and ultimately their narrative. So we identified 5 frames that are existing in many communities. The first will be no surprise to many of you that a dominant narrative in many communities is that health is simply an individual responsibility. Sure, there are systems and structures that influence in health, but it ultimately boils down to the individual. So in those communities, the messages are really about personal responsibility, personal expectation. And we certainly saw that play out in pandemic messaging in many of these communities. Now, some communities kind of ebb and flow with quick spikes because a health area is of interest and then perhaps not durable change. So for example, there are communities that we studied that are concerned about a particular alarming health trend. Of course, the pandemic is an alarming health trend for us all, but an opioid crisis or a mental health concern or a food environment concern. And that's often followed up by intensive, focused action. The challenge of that is that that can really move progress in a community on a particular initiative. But the question is, does it lead to systemic or transformational change? That's an open question. Now, a third frame is this idea that health is important, but really in service of a broader mandate to strengthen the economy as the priority. In these communities, they often approach the issue of equity through the economic equity lens, and they don't distinguish with a health equity focus, that if more people have access to economic opportunity, then there will be downstream benefits to health. While some of that is certainly true, as we know, economic gain and health gain are often inextricably linked, the question for those communities is to what extent health is really built into those health and all policies or those health and all decisions. As people pursue inclusive growth strategies or community revitalization or community development, if health benefits are not front and center in that conversation, do they ultimately show up in sustainable change? A fourth frame is the idea that people are embracing the role of social determinants of health, particularly the role of the health environment, and that healthy people ultimately need healthy environment. So the natural and built environment matters, the social and cultural environment matters. And in these communities, they're taking steps to think about how to create more walkable communities, how to ensure that there's environmental policies that protect people's safety and health. And that's all really exciting. And it's an embrace of the idea that zip code is a critical driver of people's health. But the question is, to what extent is that really unpacking issues of inequity? Or is it potentially papering over harder discussions around inequity and health outcomes? And then finally, a much smaller subset of communities are going full tilt in many ways directly at the issue of health equity, saying that it is time to address systemic racism and other sources of inequity, going backwards in order to go forwards. And this is showing up in all sorts of ways, whether equity becomes a lens by which policy decisions are made, whether communities are bringing together truth and reconciliation processes to address past harms and legacy issues. And it's coming up in how people are talking about racial injustice, social injustice, and other forms of inequity, and thinking about going to root causes rather than looking at more immediate causes. Of course, each of these frames has their value in the conversation about health. The question is, how do they exist together? And if communities are only in the frame of health as an individual responsibility, or we should, reverse alarming health trends, does that get them far enough in a holistic way to think about health and, of course, broader well-being? And does that get them where they need to go in terms of health equity? We'll continue to study this, but it's an important thing that I wanted to share with this audience, to ask yourself, what is the community narrative in the communities for which you live and work? And what conversations have you had about that community narrative? Now, we notice that there are essentially 4 barriers to the adoption, particularly of the frames that allow people to move towards health equity. One is this idea of individualism. Now, individualism has been a benefit to the American progress story in many really important ways. But the question is there a tip over to a notion of hyper-individualism? Have we lost a sense of community and collectivism that has been important, not just during the pandemic, but in terms of dealing with other health and well-being issues? A second, which is an unfortunate truth that we deal with as Americans today, is the unfortunate worsening of polarization. Of course, it's not just specific to health, but it trickles down into health and challenges us to create a shared value and a shared narrative about health, even in the context of a massive infectious disease like COVID-19. There are governance challenges. So as we talk about integration of health investments or health in all decisions, if we continue to have structures that impede goodwill because there are funding silos or RFP silos or measurement silos, it's going to be harder and harder to adopt these more expansive health frames. And then, of course, it takes a lot of courage to take on the issue of racism or other sources of social inequity, because it spurs difficult conversations, it catalyzes dialogue that's uncomfortable, and it's quite frankly difficult to enter into those conversations. So again, as you think about the communities in which you live and work, how are you addressing these barriers? What are the openings to mitigate these barriers in order to have authentic and expansive dialogue about health equity, and well-being? Now, another piece of the narrative conversation that I wanted to share moves from the community level to the individual level. Individuals are nested in communities, but individuals aggregated do not a community narrative make. Nor does a community narrative fully give you the story on what individual American public sentiment is. So for the past several years, also with the Robert Wood Johnson Foundation, we have been unpacking what are American health attitudes and values. What is actually the American health mindset? And we've done this through something called the National Survey of Health Attitudes, and we'll continue to do that in years to come. But over the last year and a half, we took the National Survey of Health Attitudes and created a special survey called COVID-19 in the Experiences of Populations at Greater Risk. The link is at the bottom of this slide. And the objectives of the survey were to focus on a national sample of underserved populations, especially in terms of income, race, and ethnicity. And while a lot of surveys were looking at the experiences during the pandemic, wage loss, health impact, and the like, We wanted to also look at something that was being understudied. How were these populations thinking about COVID-19 in the context of health equity? Did the events of 2020 and the pandemic in particular, but not exclusively, catalyze new thinking amongst the American public? Did it evolve as communities continue to experience impacts, but also recover? We wanted to know, if not now, then when, in terms of a change or an amplification in people's recognition of things like systemic or racial inequities. And what we found was both affirming at how difficult it is to move public attitudes, but perhaps surprising to some of our colleagues, because the views really were relatively stable. There was some shift initially, perhaps in July 2020, but in general, people's views are fairly entrenched. And we asked a few questions about their different aspects of systemic racism, the recognition of race and health inequity, and so forth. So one of those items, which is near and dear to a lot of public health leaders, is the notion that racism is a major public health crisis. In fact, many communities, as you know, across the country are declaring it so. But we asked the question, is the American public with us? And the answer is not a majority. Yes, there's a sizable group that recognizes it and at least somewhat agrees to the statement, but the movement was not there. There was not an awareness that markedly increased over the course of the year plus. We also asked several other questions, and we just highlight two others on row 2 and 3 on this graph. We asked a series of questions that we've done actually before COVID, where we say, are different groups at a disadvantage in terms of getting their access to healthcare? Is it easier or harder? Now, this question here on the table is about whether people think African Americans have an easier or harder time getting care. There are also questions about geographic differences and income differences. And what is notable for this item and a question that we have about Latino differences is that we still are not past the 50% mark in people's recognition that there are racial inequities in terms of access to healthcare, even in the context of what we were observing in the pandemic. Now, notably, Americans do generally endorse geographic differences in access to healthcare. There's a recognition that there are rural barriers to access to healthcare and that there are income barriers, low income having more barriers to healthcare than higher income populations. But on race, we're stuck. We also ask a pointed question broadly about the existence of systemic racism as a key reason for poor health outcomes. And again, not past the 40% mark, really, not a big explosion in terms of people's recognition, even though every media outlet was talking about race, equity, systemic racism in ways that we had never heard before. And then, of course, there was some movement for some groups. There was about a third of individuals that moved back and forth, changing attitudes towards more recognition of things like racism as a public health crisis versus moving away from it. And what this says to us is not that people are not mutable, that they can't evolve in their views and attitudes, but there's going to be more churn in these views unless we make a concerted effort to help people understand these issues better, to not just rely on the events of 2020, George Floyd, or the pandemic to carry us through. What else are we doing to tell more relatable stories? What are local journalists talking about? What are local public health departments and healthcare systems talking about with respect to this topic? How are they using new language and terms so that it sticks for the American public? And what's interesting is that we've got subgroup differences, and I'll just build this out. You know, for example, there were some notable racial differences where we saw more movement amongst people of color than amongst non-Hispanic white respondents. We did see Asian American respondents moving towards recognizing racism as a public health crisis. We don't know what's behind this, but it could be related to some of the experiences of the AAPI community during COVID. We also noted that the higher income and higher educated respondents were less likely to move a lot. Now, they tended to endorse these ideas at a higher rate, although not significantly higher, that there's not more education that needs to be done. But again, it suggests to us as we think about frame, as we think about community narrative and local messages and stories, going back to that schematic, how are we talking about these issues if we actually want to make progress on health equity? So that's narrative. Now let me talk a little bit about the measures category. And of course, everybody wants to think about, okay, what data do we have? How is that driving community decision making? Are we making a difference? And how is this situating in a context where there is a little bit of a growing recognition around health equity, and well-being? So first, let me talk a little bit about what's driving us to a conversation about thriving and flourishing in the first place. People are making the distinction between communities that survive to communities that thrive. Why? So there's a greater recognition, very much in the spirit of what I shared at the outset of this presentation, that communities are on the hook. They are responsible for populations needing support. And they can't just plan for health in silos. They have to think across all of these dimensions: physical, mental, spiritual, emotional, and social, and they have to bring it together. There's greater recognition of that, and that has been important as a driver towards thriving and well-being. Another set of initiatives or efforts that has moved this conversation is that there's a recognition that as people age, and particularly as at least some of us get the opportunity to live longer, that we have to make communities as age-friendly as possible. And so embedded in those conversations, as we ask whether people can age in place, as we think about where we want to support intergenerational housing and support the range of generations to lead healthy and productive lives, well, then of course we have to think about communities in a new way. And that new way requires a broader orientation towards well-being. And then finally, because we're having really interesting innovations and advancements in technology, that's not only just helping us map our biometrics, but actually take stock of our broader well-being. And because we're having really interesting discussions about community design, people have started to connect the dots and say, well, some of these technology conversations and these design conversation, well, goodness, they affect well-being. And so these three areas have really influenced and pushed us over to a new era where well-being has been more centered in the dialogue. And so this is our definition of well-being, just as a kind of a marker, and there are longer and shorter definitions out there. But our definition is that well-being refers to the comprehensive view of how individuals and communities experience and evaluate their lives. And the reason why this is important and more expansive than other definitions is that many times in well-being, it gets conflated with just mental health or wellness, which it is not. And the evaluation of your life is in relation to the context, structures, and histories in which you live and work. And so this definition, we feel, is much more multidimensional and takes into account not just only individual subjective well-being, but the aspects of community well-being and the role that communities play in influencing health and well-being outcomes. This figure might also be helpful in this context. Of course, individual well-being matters. The subjective experience of whether you're satisfied with your life, whether you have hope for the future, whether you have hope for your family, that matters. But we also have to think about community well-being and civic well-being. Community well-being, what is a community doing to invest in amenities and services and resources that actively promote well-being? What's the culture of a community that actively advances well-being, going back to our community narrative conversation? And then what are the policies, governance, and structures that advance well-being in the context of civic change and civic infrastructure? And of course, we all situate in the well-being of environment and the planet. So as we continue to talk about well-being, there's been a greater embrace of these outer rings, this ecosystem of well-being. Now, we've been working with several communities to advance the idea that well-being is a community responsibility, not just an individual responsibility. And I'll talk in a minute about a project in Santa Monica, California. But I want to lay out why we've gotten to this place. And many of you have seen the conversations outside of the United States about well-being. New Zealand, the first ever country with a well-being budget, the Canadian Well-Being Index, the European Union always talking about well-being in the context of economic progress. So in some ways, the US is a little bit late to the show, but many communities in the US have been thinking in this way over the last few years. And it started with the idea that communities can't just be about mitigating burdens. They also have to be in the proactive, prospective business, that their role is also to support the well-being of residents through policies and programs. That it was important to not just measure local revenue, but holistic outcomes that tell something about the social health and economic progress of a community. And well-being provides an opportunity to knit together actors in a way that it's not just governmental and everybody else, but that the role of civil society, nonprofit organizations, the faith community, and business sector to influence well-being. Chris Smith, who was a part of the Santa Monica project, which I'll mention now next, said this: it's important for us to know that we're seeing a holistic person with different needs, essentially, he's saying, and connecting across departments at the city government level so that they are not siloed and yet investing in the well-being of their residents. And that has been a very powerful motivation for work that's happening in communities across the US. So we were fortunate to work with the Santa Monica city government through a project that was competed and eventually awarded through Bloomberg Philanthropies. Some of you may be aware of the Mayor's Innovation Challenge that Bloomberg Philanthropies put forth several years ago with the question of, give me an idea that will transform government, local government, city government, community government, and the like. And Santa Monica, working with myself and others, said, rather than trying to reimagine other important things that are happening in government, change our financial system, make sure that our contracts and procurement is working effectively, all really important things, they had the pretty kind of heady concept of, what if we restructure local government around the concept of well-being, so that every government agency and the mission of government was not merely to execute efficiently, to issue those permits, as Chris Smith said on the prior slide, but to actually improve well-being. What would that look like? And to everyone's happiness, but also surprise, Santa Monica was named one of the first 5 awardees for the inaugural Mayor's Innovation Challenge back in 2013. So this project has been ongoing for many years, but it gives a blueprint for that prospective look of what other communities are now doing and thinking about in the post-COVID conversation. So our project proceeded in 3 phases. What is well-being? Define it, figure it out, measure it, and then act upon it. Make sure that the concepts of well-being got to that point of transformative local government. So Rand, working with the city of Santa Monica, said, well, first of all, let's not recreate the wheel. Let's look at all of the well-being measurement frameworks that are out there, both in the US and globally. Let's bring together leaders in many fields, health, environment, economy, education, and the like. And let's take a look at both what is the best science, but also what is actionable at a city government level. And we looked at a lot of frameworks out there, which are terrific. Some of those frameworks had a lot of domains, a lot of dimensions, 10, 15, 25. And we said, well, they all kind of boiled down to the 6 areas that are noted on this slide in purple. And we said, this is a way that we can organize the work of Santa Monica around strengthening communities, around the preservation of place and planet, around the opportunities for learning, the investments in health holistically, economic opportunity. And those 4 investment domains or dimensions would ultimately influence individual and community outlook. At a community and at an individual level, we'd have more people flourishing, more sense of autonomy, more life satisfaction, more connection. And we also identified 3 subdimensions under each of those main dimensions, under community, civic engagement, and community identity, under learning, and access to learning. And the goal of this framework was not only to guide Santa Monica, but to say we will create usable tools, and I'm happy to share with anybody offline, that other communities don't have to go through the steps that we did. They can take this well-being framework, they can take the dimensions and the subdimensions, and then they can adapt it for their local context. And that was a fundamental principle of this work. As many of you know who do intervention work, even with the best laid plans with a curriculum or an intervention designed to the T, when it's actually applied, people make adaptations for cultural, personal, systemic, and organizational reasons. And so the items in blue were some of the measures that we used in Santa Monica, but we left it open to other communities adopting our work to say, you pick the measures based on your available data, based on what is valued in your community, based on your community's goals. Don't deviate from the purple. Don't deviate from the core dimensions. That's solid, but have the room to think differently about your data. Now in Santa Monica, what that resulted in was an index that was populated with many data points that included city administrative data, non-city data, resident survey data, and social or social media data. At the time, we started with Twitter and Foursquare, and of course, advanced to things like Instagram and other platforms. But the preponderance of the data that we felt would make this sustainable for city action was that most of the data came from administrative and non-city data administrative sources. That would make it more durable than simply relying on a survey. And given that we were not just looking at individual experiences of well-being, to my earlier point, but community investments in well-being, it was critical that we tracked those community amenities, or what we often called well-being detractors, influences in a community that take away, that don't positively promote well-being. So for example, this lifted up a lot of really unique findings across the dimensions. I'll highlight a couple of survey findings that I think are representative of why the well-being frame changed the terms of the conversation in Santa Monica. Santa Monica prided itself, and it's a wonderful city, on a lot of community connection, on the city by the sea, even though they knew that they had economic equity issues and other concerns to be worried about. It wasn't a utopia. But I don't think that they thought that a third of their population was as stressed as it was. And we know that that matters for everything from mental health, but also work productivity, life productivity. And when they looked at these findings, they had a roadmap for acting. Another area that surprised them, but provided them a roadmap for action, was that there's a lot of community activism in Santa Monica. And they also felt that that translated to a sense of neighbor to neighbor connection, that people felt that they could count on their neighbors, which is a very important measure, as you know, in Nebraska and other places, that people can count on their neighbors. And yet, when we asked people this question, the numbers were far short of the national average. Well, this gave Santa Monica something to work on. How are they connecting between government and community organizations? What programs could they put in place to inspire more community connections? How could they make sure that people from one zip code talk to people from another zip code to create a much more friendly and supportive environment? And why that mattered, of course, is not just about the well-being of the residents, but it also mattered in terms of the economic future of the community and the ability to retain residents. And there are many other indicators of this effort, and I can certainly point people to the website, but we continue to measure these things over time, every couple of years. And that was an important part of the measure part of define, measure, act. Well, what was action? Action was actually using the index to drive and frame local progress. So the well-being framework became the framework for the city budget. Different departments in the city had to explain how their investment requests were going to address dimensions of well-being. They also used the well-being index to inform downtown activities and a downtown community plan. Now, after several years, the well-being index has moved into a nonprofit organization called Civic Wellbeing Partners. Civic Wellbeing Partners still continues to work with the city, but also other cities around the country and internationally to bring this framework, to bring what we did in Santa Monica to other communities. And it has been really quite tremendous. Now, again, just like in the narrative, I talked about community and then I talked about individual. I'll do that again here. We talk about holistic community around well-being and reframing the business of local government. But there's also a way to think about well-being through the prism, through the lens of individual progress. One of our primary measures of American progress is the GDP mentioned earlier, the gross domestic product. If you asked any economist, while the GDP has its flaws, it's still extremely useful and a standard bearer in terms of how we cite whether America is doing well or not. Well, why not take that page and say, what else should we be measuring to redefine progress in a way that is more well-being centered? And we came up with the concept of GDP2, or the gross domestic potential, not to replace the GDP, but to complement that relatively narrow economic indicator, to embed well-being into the way that we measure both individual and societal progress. The other reasons to create the GDP2 is that we wanted to acknowledge the changing epidemiology and development of children in our country. As many of you know from either your work or being a parent, and the pandemic has been no exception, there are new expectations on our children to navigate a new world. Well, how are we capturing whether we're investing accurately and effectively, acknowledging those changes? The GDP2, as I'll explain in a minute, is a way of thinking differently. We also recognize that even though the GDP is an important measure of economic progress, at times it can map and mask deep drivers of inequities. How do we actually think about the front-end investment, the upstream investments that downstream result in challenges to our economic progress, both at the national level and at the local level? So in working between RAND, the University of California, Los Angeles, and Children's Hospital of Philadelphia, we constructed the initial stages of a framework called GDP2 that would measure how human potential develops and how it creates the conditions of people to thrive. So what does that mean? Essentially, our construction of GDP2 is the first attempt to capture the potential of a nation, not just by the GDP, the gross domestic product, but by assessing the capability promise of its youngest cohort. And we talk about this in a short commentary piece called How Are the Kids Doing in Health Affairs? And I commend everyone to look at that. Because as the pandemic has been raging on, we've had really spirited discussions about whether we're investing in children and whether we had our priorities in order. And I'm sure that many will agree with me that we did not, and we were not aligned in terms of our investments with children. Well, what if we had had the GDP2? We would know where we were leading and where we were lagging in terms of our investments and what matters to actually on the front end help kids thrive and flourish. So then when we get to the community well-being framework, as in Santa Monica, that we've tied the two pieces together upstream and in many cases downstream at the community level. So I won't go into this kind of wonky framework, but it's all to say that GDP2 is not Pollyannish in the idea that we can just measure capabilities and call it a day. We need to invest in children's capability and development to thrive and flourish, but that has to be met with opportunity. And this is where the equity conversation is. And it's in that intersection in the investments and capability with the opportunity to unleash the capability that results in potential. And it's the actualization of that intersection that ultimately leads to this notion of thriving, that shifts the conversation of children who can just survive, to children who can thrive, to adults who can thrive, to communities that can thrive. So the first phase of the project is now done. We're in the process of working on getting deeper on the measures. But we ultimately landed by talking with a bunch of people around the country and kicking the tires on what mattered and working through a lot of sorting activities and Delphi activities and the like, that there were 7 developmental capabilities that mattered today for which we need to measure in order to drive community action, federal, local, and state policy. Of course, the ability to live a healthy life, the ability to navigate systems to satisfy basic human requirements are important. But these other 5 are also important. The ability to understand verbal and nonverbal communication, all the more critical in our virtual environment. The ability to evolve and expand and learn across the lifespan and how communities are investing in it. The ability to adapt to social, cultural, and technological change. Of course, the COVID-19 provided all of the reasons for that capability. The ability to connect to others and the environment, critical in the context of a changing demography, and an ability to navigate critical issues like environmental protection and climate change. And the ability to understand and civically engage, all the more important as we're having really tough conversations as Americans about our democracy, about self-determination. And in all of these investment areas, the idea is ultimately, how can we shift the terms of the conversation to measure the right things that help us invest on the front end in human potential and on the downstream end in ongoing investments in community well-being. Now, as we think about putting well-being first going forward, there are 3 major questions to consider, both in the context of narrative and in the context of measures. One is, how do we help communities keep a focus on well-being as new emergent issues can sometimes take us away from some of the holistic and strategic work that's required? We have to think about the policies that link to the well-being metrics. In Santa Monica, we did this work by looking at our community dimension measures, for example, and tying it to policies and deliberations that were happening in local government. And then as we think about designing our communities, both the physical design, but also the social design, how do we reimagine well-being oriented development? We've talked about person-centered development. We've talked about age-friendly development. Well, what does well-being oriented development fundamentally look like? And for health leaders, how are you part of this conversation going forward? Now, in my last section, which I'll be brief about, I want to raise up that 3rd stream, that 3rd action area, which is policies and systems. Narrative change and measures change the terms of the conversation and reprioritize what matters. But unless there are structural policy and systemic change, we won't have the durable transformations that we know we absolutely need. So when the next COVID happens, we're not caught flat-footed talking about the same systemic fragilities that we were talking about over the last couple of years. So this is another effort back to our work with Robert Wood Johnson Foundation that we're very proud to share with all of you. And it's an effort that RWJF funded, but was an independent commission led by Gail Christopher and many commissioners representing health and non-health sectors, representing business, government, tech, nonprofits, community-based organizations, and the like, to take a look at the COVID conversation and say, if not now, then when, in terms of reimagining our public health data systems and making recommendations to create an equity-centered, modern, transformation-minded public health data system, inclusive of healthcare data. And RAND was privileged to create the supporting white papers that informed the commission. And the commission report and associated products are available for download at the footnote below. But I want to kind of knit together this commission as illustrative of some of the systemic and policy changes that are possible. And I won't go into every recommendation area. I commend you to look at that commission report. But we essentially organized the recommendations in 3 areas, and the commissioners were just fantastic in terms of their leadership. And it speaks to the systems change that we've been talking about over the last hour. There's a significant focus in the conversation about transforming public health data systems with narrative. Now, often data folks don't talk with narrative folks, but we must if we're going to center health equity and well-being. There are recommendations about community engagement and agency and the conversations about what gets measured, how it gets measured, how it gets analyzed, and how it gets translated into action. And many recommendations about the movement towards equitable and equity-centered governance, and not just at the federal level, but at the local level as well. And then finally, many of these themes that we've been talking about over the last hour, ensuring that public health and health data measurement, well-being measurement, captures and addresses the upstream drivers of health inequity, including but not limited to structural racism. And there are recommendations in each of those areas. The other way that the commission worked was also thinking about sector recommendations, and I'll just highlight a couple as illustrative. So we made recommendations for local government. And one of the ones that shouldn't be transformational, but in many ways is disruptive, is the idea that we have to connect public health data to just general local communications. How often, if you think about your community, think about your mayor, think about your commission or city council, how often are they connecting health into a broader story of community well-being or a broader story about inequity? Often health is siloed in this conversation where we're presenting data on the pandemic impact. But what if health was more centered in the conversation from the state of the city address that a mayor might have, or other kinds of community leaders that are non-traditional health? That matters for the narrative. We've talked already about the issue of community engagement in data, but to make sure that that governance is hardened and solidified. And of course, thinking about the role of government in activating data sharing collaborations. In Santa Monica, if we hadn't engaged with civil society, we wouldn't have created covenants to generate public health data from all sectors in ways that advance public-private collaboration, but also help to center equity. All of the health equity data does not sit with government. So how can government more effectively work with these civil society actors? We also looked at nonprofits, and there are many other sectors in the commission report, healthcare, public health, and the like. But for nonprofits, when was the last time that we really moved on having trusted data? And given what we observed in COVID-19 and a diminishing trust in data and institutions, there's a role for nonprofits to reassert trust in data as a public good and to do it in a way that tells the equity story, but doesn't further marginalize or bring harm to populations. And of course, the role of nonprofits in that mutual reciprocity to share data, but to understand and be able to then clearly articulate the health benefit to the constituents that nonprofits often serve. So to close, it's worthwhile to go back to the prior questions. Can we be better in acting on what we knew before, not take 5 more years or 10 more years, but act now with greater urgency and focus? Can we be more holistic about the frame on health and what influences health? And can we move from rhetoric to transformational and structural change? The commission work is an example of trying to move to transformational change. But there are local versions of the commission work that need to be activated, whether in regions in Nebraska, whether in the Midwest, or whether at the local neighborhood level. There are versions of everything that I've shared playing out in communities across the country. And if I leave you with any kind of scaffolding to frame your work going forward, it's that you can't short shrift any of these areas, that actions need to happen concurrently and in interconnected ways across narrative, across measures, and across policies and systems. Now, I am definitely optimistic and cautiously so that the future is bright, that we will finally take some of the lessons and insights that COVID gave us to move towards broader discussions around health and well-being and a recognition of how we center equity. But as we know, the window may close without a lot of courage, a lot of action, and the individual and collective roles with many of you who are listening today. And I have 4 kind of takeaway points that I say are absolutely critical to embrace going forward. One is to look at the work that you're doing and the extent to which it's leading to an authentic understanding of what actually is influencing health, what actually is motivating individuals in your community, and starting from that place. Relatedly, how can we move to new and innovative frames that stick with the American public about the importance of health, the purpose of health, the importance of well-being in that broader context, and the value of talking about structural and systemic inequities? What are the things that we're doing to disrupt in our own work? Whether it's picking a different measure than you did before because it sets a new conversation about health inequity. or it sets a new conversation about positive health and well-being, or picking a new collaboration and shifting the terms of that collaboration. What are the disruptions that will ensure that everything that we've talked about today can go the distance? And then finally, going back to the work in Santa Monica, one of the most impressive things in Santa Monica was not the framework or even the framework to action. It was sitting with government departments and saying, why are you collecting and analyzing those data? Does it actually tell you something about well-being? Or is it just something that you've done for years and you're just keeping on doing it? How do we actually shed what's not working for us in favor of measures that actually center equity, health, and well-being? And with that, I will thank you for your time today. I wish you a terrific conference discussion. And I have listed my email if you would like to reach to me with any questions or comments or keep the dialogue going. I can certainly point you to many of the footnotes that I had on slides, to RAND reports that are always freely downloadable. And I look forward to continuing the conversation for years to come. Thank you so much.